Welcome to Psych Incubator, and Eminent Psychotherapists reveal the product of strategic psychotherapeutics. We are very pleased and honored to have as our guest tonight, Dr. John Norcross, who is an internationally recognized expert on behavior change and psychotherapy. John is a distinguished professor and chair of psychology at the University of Scranton, clinical professor of psychiatry at SUNY Upstate Medical University, and a board-certified clinical psychologist. John is the author of more than 400 scholarly publications and has co-written or edited 22 books, most of them in multiple editions. Some of them include the 5-volume APA Handbook of Clinical Psychology, Psychotherapy Relationships at Work, and more and more and on and on. So I'll let you read his bio on Psych Incubator, because I don't want to take up too much time. But I have known John for probably 2 decades in various ways, presenting and discussing, and just love John's passion for psychotherapy. He is the penultimate scientist practitioner. And I always, John, whenever you've presented, I always am just amazed at how engaged I am with what you do, because you're an awesome presenter, and I always try to model, like, how does John do this, because he does it so well. So thank you for joining us, and Michael should be joining us in a minute. Let's just get started. We'll stop at 8 o'clock, the recording, and then we will just have a time to talk without recording to debrief for a little while afterwards. So let's get started with our discussion.
John, thank you so much for joining us.
Why
don't we kick it off by just telling us a little bit about your background and what brought you to the world of integrative psychotherapy?
Well, Lizzie, it's like most complex things, a confluence of influences. I have parental models. I have family dynamics. As a second-born child, I had some early, very influential faculty mentors. And then, of course, I have clinical training. And of course, the ultimate clinical training is seeing patients who, frankly, require you to be integrative if you're seeing a heterogeneous lot. So my parents were sort of an unconventional lot. My mother was one of the earliest park rangers for the National Park Service down in the Tennessee Smoky Mountains.
Really? Wow.
My father, by contrast, was a labor organizer from Philadelphia in southern New Jersey. So he was down there trying to organize a factory in Tennessee back in the day when this was radical and potentially dangerous, where he met my mom. So from the early days, I was just got accustomed to diverse cultures and people, different religions, the North, the South. I'm one of 4 boys, the second son. If anyone's aware of the research evidence on ordinal position, the second born, according to Sulloway, is born to mediate and rebel.
Mediate and rebel, because we both share that, John. I'm the second of three boys, and
rebellious mediators.
Mediate and rebel. Interesting.
So the mediator is a perfect metaphor for someone who's integrative, but at least when I began, integrative was a bit of a rebellious against the cultism and territoriality of theoretical orientations back in the day. I was fortunate to be trained at Rutgers University by a behaviorist, a psychodynamicist, who was a student of Hans Strupp, where I met Hans, a cognitive behaviorist, and a multiculturalist very early in the day. And they emphasized I could learn from all of them. There wasn't the usual therapy wars and nastiness associated with that. Then, just by pure circumstance, I end up as the first paid research assistant to a relatively young Jim Prochaska, who had just then got his first major grant and began the stages of change. which of course is all about stage matching. And subsequently, Jim has probably secured more external grant funding than any psychologist on the planet. I think he and Carlo Di Clemente are over 120 million now.
And I got to
Wow.
say that I use that with every patient that I see. It is such a useful model because it's what approach at what time in that stage change.
That's right. And that is, in fact, I would say the ultimate aim of being an integrative therapist, Lizzie. As I like to say, the first step is to get rid of the theoretical blinders and restrictions, right? To open it up, to mix and match.
Biases.
But the second is to know what to do what to do, when to be more insight oriented, when to be less directive, more directive, when to use this, when to use that. And that's been really the thrust of my career. Be integrative and then personalize it.
Can you say, John, could you say what integrative is for people who are watching and may not actually be familiar? Like, how would you characterize integrative psychotherapy?
So integrative psychotherapy or psychotherapy integration is the conscious use of multiple methods associated with different theoretical orientations. And concomitantly, not to be restricted or restrained to a single theoretical orientation. There's lots of ways, of course, of doing it, and at least a dozen or so terms for it, right? There's pluralism, eclecticism, integration, rapprochement, unification. They're all variants on the theme, and there are some technical distinctions, but ultimately use what works. And of course, I must say, there's different paths to integration. I tend to trust the one that's more heavily rested on the research evidence. Some people are a little more guided by theoretical prescriptions. I'm just a little too damn pragmatic. I want to see some compelling research evidence that stuff works.
So how does that differ from technical eclecticism?
A little bit. So technical eclecticism tends to focus only on methods. They largely ignore the therapeutic relationship, which I obviously think is a massive mistake.
Yes.
And all clinicians and researchers know that.
Yes.
And secondly, technical eclecticism is sometimes too narrowly applied only to a patient's diagnosis or disorder. And yet, as clinicians, and as any healthcare professional will know, it's frequently more important to know the sort of patient who has a disorder than the disorder the patient has, as was said back in 1906. So in spirit, it's very similar to the technical eclecticism of an early mentor of mine, Arnie Lazarus. But I want us to think about methods and relationships. I want to think about tailoring or personalizing to a patient's disorder, but also to the entire personhood.
Yes. Yeah. And how much of the, like, I know you've done a lot of research on this, in these areas. How much of the variance would you say is does the therapeutic alliance or relationship account for in outcome?
So the alliance I would call just part of the relationship, but if you include all the relationship components, you're easily up to 15% of the variance that we can account for. And we can usually account for 60 to 70% of the variance in any case. So you're already up to 15% with the relationship. And as we all know, the lion's share of the outcome variance is the patient themselves. So
no, say more
only
about that.
second to the patient, the therapeutic relationship is most important.
Say more about that. I think that's interesting. The patient, what do you mean?
Well, the patient. So the patient accounts for the lion's share of who gets well and who doesn't.
In what way?
We frequently don't think about this because we're a little therapist-centric. It's all about what we do.
Yeah.
But we know it's the patient's severity, their motivation to change, their stage of change, their psychological mindedness, the amount of support they have, their functional impairment, their willingness to work, to trust, their attachment style. These are all pre-existing patient characteristics that have huge impact on how well they're likely to do.
So are these the Yavises that Sifnios used to treat in his short-term therapy and got good results? The young adult, young, attractive, intelligent,
Successful.
successful. Thank you. Is that sort of what you're saying?
Well, it's sort of, but it's
The
more than
healthier
that.
you are, the healthier you are, the healthier you get.
Well, and that sounds sort of terrible when you put it that way, Jeffrey. I prefer to think, isn't that true of virtually everything in healthcare and education? The brighter, more motivated people tend to do better in education. The brighter, better, healthy patients tend to do better in healthcare. Period, right? I mean, whether it's cancer or oral health or anything.
Maybe we
So
don't.
I know at times it can feel like you're picking the easiest patients. I don't mean it that way, but it's a reality. By contrast, Lizzie, we were speaking, you're working with the severely mentally ill.
Mhm.
You know very well that simply decreasing relapses and rehospitalizations is a huge, huge improvement in their lives.
Mhm.
By contrast, if I'm seeing mostly neurotic outpatients, that's not even a concern for me.
Mhm.
So after the patient's contribution to getting well or not getting well in psychotherapy, it's then the therapeutic relationship that is most curative.
Absolutely. Absolutely. I have a question about, building the therapeutic relationship. I was actually speaking to someone the other day who said that they had a therapy session over text and they said it was terrible, and I was not surprised. What do you think about the, ability to build truly therapeutic and helping relationships over Zoom and or text or phone? I guess they do that now. But what do you think about that? Is it possible?
Oh boy, that's a big,
It's a loaded
complicated
question.
But let me start with a couple of research findings of recent meta-analyses. The alliance and the relationship is as important in teletherapy as it is person to person, face to face.
Mhm.
However, the overall level of the relationship is slightly lower via Zoom or any other video conferencing compared to person to person.
Huh.
Frankly,
Makes
I'm
sense.
surprised it's not even much lower. But that's particularly for patients who begin and end through video conferencing. If you have an established relationship with someone, then an occasional Zoom call, or even for that matter, telephone call, works quite well because you know the patient. But had to never just physically see a patient, you're missing so much crucial information about nonverbals, cadence, all that kind of stuff.
Absolutely.
So the relationship is as important. So we know it's a curative factor, whether you're Zooming or not.
Mhm.
Why do you think that is? I'll tell you right away. I'm terribly biased towards Zoom or this kind of thing, and I think this focuses more on getting people to look at themselves and look at you. You can look at yourself and look at them. And normally, the therapist is blind about themselves as they're working with the client or patient. And so you get a benefit there of increased awareness in the therapist. Secondly, that you can have your patient client recording the session and they can look back over it. And many patients tell me they really didn't understand some of it. Some of it wasn't clear. Some of it, as they look back over it, they could figure it out. And then they could tell me even more clearly what was going on. So I find it to be a tremendous time saver, saves time, everybody going to and from the place, healthier, no one's going to cough on you. And today is, flu, virus, death, black plague. So
Monkeypox, yes, they're all out there waiting for you, Michael.
So you can sit in your office and they can sit in their room and you can really see them very closely. You can see the expression in their face. You can get
Well, Michael, you and I have no disagreement. I was responding to the question about the therapy relationship. I'm a big fan of access to mental health. Let's face it, we're in a global mental health crisis here.
Yes.
So there's lots of other advantages to telehealth, including immediate access, privacy. I think you can record whether you're in person or not, though it's easier for most people to push a record. But I've been recording sessions and encouraging patients to do so for 30 years. So there's nothing really new about telehealth in that. But it's absolutely true. Therapists can see themselves. Those of us who regularly videotape our therapy sessions and do deliberate practice been doing that as well. But it's private, it's full of access, it saves time, it helps the world address a mental health crisis. So I agree on all those benefits, but sitting in person tends to enhance the therapeutic relationship by about 10%.
Is there research on that?
There is.
Obviously.
So 10%,
But that's a 10% compared to the multiple benefits of Zooming.
yeah.
Particularly if you're in a rural area or you can't get away from work or privacy or the time of day, there's much to recommend. But whenever possible, I do encourage my trainees and supervisees to try to see someone in person at least once to establish the relationship.
Yes.
Now, it is true, the flu and cold season's coming, Michael, so we should be careful about that. I'm also,
I'll wear a shawl or something.
well, there you go. Well, just your mask. But we also know there's some fiction going on about patient fabrications and misidentification if you don't see them in person.
What do you
What do you
mean?
mean? Yeah. What,
Well, they're not who they say they are.
Really?
So if you're offering single session therapy, frequently people are providing misidentification in order to protect their privacy and confidentiality.
single
Oh.
session.
Hmm.
What is?
Well, a single session psychotherapy or people doing telehealth initial consultations. There's now research suggesting that patients frequently do not provide their real names.
Oh,
Huh. Interesting.
As the therapy begins to click, do they begin to get some trust? And
Well, that hasn't occurred to me. That a patient has not misidentified themselves, at least to my knowledge. But it's happened at our counseling center. It's happened up at SUNY. So one needs to be careful with the patient you don't see, you don't have identification, or at that point, even an insurance card.
but you could fix that easily by having them scan in their insurance card so you'd see it. And
If they decide to, yes, if you accept insurance, but for the increasing number of mental health professionals operating fee for service, insurance will not even come into play.
yeah, yeah.
well, okay, that's it's very interesting.
We could get into a discussion about the telehealth.
It's a
'cause I'm
side
worried
issue. Side issue.
about that, But
We got
let's,
better stuff.
yeah, let's stick with the
So
all, I'd like to just
I'd like to
suck
hear.
out of your brain all the stuff about.
You've got a ton of
integration.
information. I know when you talk about the 5 key steps. I wonder if you could elaborate on that, since that seems to be the changeability factor, and that's been narrowed down. You write about it very clearly. Is that what's closest to your heart, or something else right now that you think is more important?
Well, personalizing is probably the closest to my heart right now. And one of those is the stages of change. Mostly every mental health professional begins to nod and say, oh yeah, I know about the stages of change: pre-contemplation, contemplation, preparation, action, maintenance. But when I say, so how do you use that? Most of them draw a blank. You just kind of know them as stages or steps. What's most important is once you know, as Jeffrey said earlier, where a patient is, you know from decades of research what tends to work best.
Yeah.
So in pre-contemplation,
Motivational.
right, we used to know it as denial, right, Jeffrey?
Yep.
But what a pejorative term. How to turn off a patient, just tell them
Yeah.
they're in denial.
Yeah.
We know that more insight-oriented therapy. Carl Rogers, which today is called motivational interviewing, helps them move from pre-contemplation to contemplation. Once in contemplation, you sort of become like Socrates, working with people's cognitive and affective material, helping them establish their own sense of efficacy and motivation across the chasm into preparation. And that's sort of where the existential willpower commitment stuff works. From there, they take the small steps into action where they change their behavior environment. At that point, the research indicates you become almost like an experienced coach using some skill building CBT stuff. And we know it's not just enough to change, you need to maintain the change. So then, of course, you have the maintenance stage. And actually, if you look back just even 20, 30 years ago, we're pretty embarrassed that we just assume once patients change, they would stay changed forever. Now we know it's recycling. If you have, for example, one major depressive episode, you have about a 70% chance of having others. So we need to help people avoid or prevent relapse. And when they do come back, to paraphrase Freud, without shame or embarrassment, come on back. Because we now know that most mental health and addictions are not like the single flu, right? They're like the common cold. They come back and they come back.
You've talked a lot about a slip doesn't need to be a fall. And I've used that all the time with my work at the hospital. I mean, I think almost every day I talk about it with someone. So I think that's been very powerful. What do you think, where did that come from? Basically, was that part of the stages of change that brought that up?
Well, right about the time the stages of change were being developed, two fascinating events occurred. One is a young psychologist from the University of New Mexico showed up and said, you know, I'm trying to develop programs for problem drinkers, and I've come to realize they're in pre-contemplation. Well, that was Bill Miller, who then went on to develop motivational interviewing. About the same time, Alan Marlott and colleagues in Washington were starting, particularly in the addictions, to look at the very high prevalence of relapse. So they were developing relapse prevention at about the same time we were talking about maintenance.
Got it.
So, you know, securing maintenance and preventing relapse are pretty much two sides of the same coin.
Yeah.
So they have done, that is, Marlott and relapse prevention researchers had done phenomenal work in helping us train patients how to think to avoid, you know, the abstinence violation effect, you know, saint or sinner, how to deal with these, how to have slip cards, and how to fall forward, as they say these days, right? They just realized it was resilience training before that was a fashionable term.
Oh, interesting.
Okay, so lots of great ideas that seems like everyone right now is agreeing with. How does the way you work with this the fact that the relationship is so important fit in with these particular things? Because obviously the relationship you're building right from the beginning,
Yep.
you know, what the person is bringing in. And one of the things that happens is people, you know, if you look back at videos of your therapy, you find, you know, that they were telling you everything. You just didn't see it right away. You didn't pick up some vital cues, or you avoided it, and you know, because you didn't want to face it. But but on the other hand, sometimes, you know, we talk about, you know, you get this patient, and patient is bright and motivated and healthy, and they're just flying along. And I've learned that, boy, watch out. If they're going too fast, too much, too good, it's going to crash. So, I mean, how do, I don't know if I'm asking things that are going to work in this particular setting where you can fine tune it that much, but those are the things that seem to make a huge difference. How you pay attention to it, and how you, maybe that's the personalization. You pick out what the important pieces are going to be.
Yes, that is part of the personalization process. You know, one of my pet peeves is that so much of personalizing or integration really focuses on theories and methods instead of the relationships.
Hmm.
In fact, some people occasionally experience a little conflict between our research, like in the stages of change in the therapy relationships. And I say, well, I guess you missed those chapters in the book, because even how you are as a therapist changes in the moment as the patient talks about a different stage of change.
Hmm.
So in the pre-contemplation stage, you know, you have a patient who for the most part is denying most of the obvious reality. You need to be like a nurturing parent, not filled with judgment, instead quite supportive, joining like a defensive adolescent who needs autonomy and control on the one hand, but also have some experience near relations that it's okay to be a bit vulnerable and consider things. Well, once a patient is in contemplation, as I said, you're more like Socrates, not just cognitive, really emotive work. Later, you're an experienced coach. And once you're into the maintenance stage on a particular disorder or for a particular goal, suddenly, you know, you're more like a consultant. You may just spend a few minutes with that and then dealing with other stuff.
Yeah. Yeah.
So, and I agree, experience and good research on the therapy relationship teach me how to handle these other critical junctures that Michael's talking about.
Mm.
For example, we have lots of patients who try to fly from I don't have a problem to I'm better. So Michael, you described a fairly common scenario, which we would call, right, maybe flight into
But
health,
it's a health, yeah.
right? We don't trust that. You can't just skip the contemplation work, right? It needs to be grounded in a genuine commitment to change, a value realignment, to doing some emotional work. You just don't wake up one day and say, that's it, I'm going to stop drinking for the rest of my life.
Well,
I
you
would
do,
never
but
trust that.
You do, but then that old dry drunk thing that we used to use, I think, is pretty apt. Like you're not drinking, but your behaviors, in fact, are often worse than they were when you were drinking. People, that's when the families come in and say, oh my God, I can't tolerate this person. He's been sober for 10 years, but he's worse. I wish he would go back to drinking.
So it's a rush into action when people don't work it. So at every stage, you have some of these concerns. For example, some people can get into maintenance, but actually be a little misleading. They kind of play, we sometimes call it the Obama trick. Our former president, who I respect greatly, likes to publicly aver that he is not a smoker. Well, that is, he does not purchase and carry cigarettes, instead bums them off as Secret Service agents. So in maintenance, you know, in the relationship, you need to have enough trust and credibility to say, well, let's really talk about exactly what's occurring rather than just taking a quick, transparent self-report. So throughout any personalizing, the essential skills of knowing a patient, personalizing, and developing a trusting therapeutic relationship remain absolutely essential.
Yeah. So as you're talking, John, I keep this classic book that I'm sure you're aware of, Differential Therapeutics by Clarkin, came up, and was
Francis, right.
Alan, yeah.
Alan Francis, John Clarkin, and Sam Perry.
Wonderful. Yes, thank you. You are the scholar. Differential Therapeutics, when you read that book, how did that change your thinking?
That was a fantastic book. In fact, I still cite it regularly.
Yeah.
And I've done some work with John Clarkin in the past.
Yeah.
That's more though a macro decision book.
Say that.
It's a macro decision about what are the relative indications and contraindications for doing individual, group, or couple and family, exploratory, psychodynamic, right? So strategies, modalities,
approaches.
inpatient versus outpatient.
Yeah.
So they're the macro decisions, absolutely essential, and it's still a classic.
Yes.
But they don't focus the moment-to-moment, session-to-session moves.
So it's more like, I think the way that I have incorporated their work is more like treatment packages. Like what are the part of the packages, the format, inpatient, outpatient, the approach you're going to pick, the time, how many sessions, all that stuff in terms
Much more macro treatment planning.
Yeah. Okay, that's a helpful way to think about their work. But that remains a classic volume in my library.
I have a from left field question. For since the time that Freud left Charcot's facility and went home and tried to do hypnosis, couldn't do it, and moved from trauma as being the origin of problems to sexual
The seduction fantasy.
fantasies and the like being the core problem. People have stayed with that then as the issue until trauma became once again the big issue, and now trauma is the big thing again. And you can see very clearly, you can tie the trauma to symptoms, patients coming in agitated, and you can ask them when they felt that way before, and they describe, well, there was that day when I saw this and couldn't stand it, and so where do you put dealing with the trauma, or you don't separate it out that way?
I think you'd have to be a little more specific
Okay.
about, are we talking about the relationship with trauma, treatment planning for trauma, personalizing?
I don't think in those terms at this point in my life. I'll have to become more familiar with them, obviously. But the person comes in and they've got symptoms, okay?
Yeah.
And they say, I don't know what to do. I keep kind of losing track of where I am. I get shaky at all kinds of situations. I sit in the car and almost jump out of my seat. And so that's a presenting complaint. And
Right.
So.
Well, I could talk lots about that since the last few years of my part-time clinical practice. Over half my patients came to me for trauma. Some with the dissociative symptoms you're talking about, some with just sort of a classic, I was in war, sexually assaulted, so both single incident trauma, as well as today, what we properly recognize as complex trauma. So the therapeutic relationship and developing a holding environment is absolutely critical. Once the patient feels safe and can self-soothe, relax, whatever jargon you would like to use.
Self-regulate.
Very clear to me that when the patient is ready, some form of exposure therapy is the treatment of choice. But as soon as I say that, I rush to say when they're ready. I've seen patients ready for exposure therapy in 2 sessions, and I've seen patients ready for it in 200 sessions. So it is such a colossal early mistake to force a so-called evidence-based first-line exposure treatment on a patient who's not ready. Exposure treatments tend to work better than non-exposure treatments. Some of Vanderkolk's own research shows this quite convincingly. I think it's also a mistake to think of exposure therapy only in the CBT tradition. I think anyone who understands exposure knows it can be, yes, prolonged exposure, but it can be EMDR, narrative exposure, Judith Herman's classic work, solution focus, CBT. There's lots of exposure therapies. Once that's done, it's also very clear to me that we need more than just symptom relief. We need to work on reintegrating the person. That is a very lengthy and ambitious task, particularly for complex PTSD. For single trauma, I've seen people bounce back. So I must say, I was going to say dismayed. I am actually outright hostile when I see people saying PTSD just needs 6 to 8 sessions of exposure-based treatment. I think this is the very worst of so-called treatment guidelines and best practices. It's the exact opposite of personalizing psychotherapy.
And do you think there are clinicians that recommend that, or pure researchers who are believing in their selective protocols?
I think it's pure researchers working only with their own treatments, with very select patients in a research clinic that cherry picks patients in the action stage.
Yeah, I agree with you, because I think it is a long path to reintegrating the self after processing the trauma. And I agree with you that there are multiple ways of doing trauma therapy that can be effective. And the important part is what actually fits with the patient's values and what they want, because the best approach with the wrong patient is well, like one of my supervisors used to say long time ago, is the operation was a success, but the patient died. Like,
Yes.
I would sometimes give short-term dynamic therapy to, there was a phase in my practice where I would do short-term dynamic therapy with everyone, and then wonder why some patients never came back after. So it was the right approach.
Right.
But yeah.
Well, while I'm ranting, one of my other rants is how people are mischaracterizing the term evidence-based practice. Jeffrey, you and I know that evidence-based practice, by definition, requires 3 things: research evidence, clinician expertise, and patient values and characteristics. So many people keep telling me they're doing evidence-based practice because they looked at a research study.
Right.
If you don't have all 3, you're simply not doing evidence-based practice.
So talk a little bit more about this, because I know this. I know this is quite a controversial topic, and as someone who sat on the APA Clinical Guidelines Advisory Committee and feel like I got an MPH in evidence-based practice and all that stuff from the training they gave me to be able to actually be on the committee. There still seems, John, to be this sector in our profession that believes that if it's not an RCT controlled double-blind study, it just doesn't meet the gold standard. And how do we counter that with agencies and people who actually think, okay, that's right, because then CBT really is pretty much one of the only evidence-based therapies under that model, because they have the most research and it's the easiest.
Well, they have the most research, but certainly not the only.
Right,
but you're right. 70 to 75% of the efficacy study coming out of some variant of CBT or third wave CBT. Well, APA has tried, American Psych Association, by simply declaring that RCTs are the gold standard if you want to identify a treatment package that works. But, you know, honestly, it doesn't take a PhD in statistics to simply understand. All that means is all the components that went into the treatment package were effective.
Yes.
So you had a relationship, you had a method, you had a ritual, you had a well-oriented patient, So I value RCTs, but they're the gold standard for one specific question. They're not the RCT for everything.
Yes. Do you think there would be any benefit in looking at what Scott Miller calls the super shrinks and actually doing research on what makes them effective, as opposed to having these large cohorts of therapists who are all over the place and trying to figure out what is it that these super shrinks have that get these really good outcomes?
Well, there's now dozens upon dozens of good studies on who are our most talented therapists. You can call them super shrinks if you like. Actually, the study of this goes way back into the 1970s. You will not be surprised to hear that the overarching commonality among super shrinks is their ability to form and maintain a strong therapeutic relationship. After that, it has to do with flexibility. If you prefer, personalizing, tailoring to the therapy, and having a very clear structure and decision, if you would call it earlier, treatment planning. So we do kind of know who are the best. And I do believe we can continue all those lines of research simultaneously. Who are the best therapists? What are the best way of having a relationship? What's the best way of training people, as well as treatment A versus treatment B? But I need to tell you, 50 years into the comparative horse race of treatment A versus treatment B for a particular disorder, we've discovered next to nothing. Probably 5 or 6 exceptions, such as trauma, some form of exposure better than none. For bipolar disorders, we know people should do things. For severe mental disorders, we know we should do more of everything. But beyond 5 or 6 exceptions, those randomized clinical trials pitting psychotherapy A versus psychotherapy B have given us literally nothing.
Yeah.
Oh, we've got problems with poorly controlled therapist factors. We've got problems with horrible diagnostic categories, and so it's pretty hard to expect much better than that, because it's the old garbage in, garbage out.
Yep, and we over rely on patient self-report simply of symptom remission. We don't really know what therapists are frequently doing, and we don't even try to disentangle or disaggregate. Is it really a treatment method working here, or is it the therapy relationship working? In fact, I'm finishing a book with Clara Hill now called Psychotherapy Skills and Methods That Work. We're just trying to find, apart from treatment packages, what methods actually work. There's incredibly little good research on that question.
Yeah.
Instead, what we really know is if you put it all together, a decent clinician, some sensible treatment method, and a fairly well-motivated patient, things go fairly well. But as Michael said, it's complicated, it's a mess, and it kind of depends on 4 or 5 moderator variables. So garbage in, garbage out. Ego is a great way of phrasing it.
We have a lab group that's been working on going through the literature and picking out the techniques, the most basic techniques, like that can be depicted in a patient therapist dialogue. And you wouldn't be surprised to know, and you already know this, but that there is absolutely no evidence to support any technique. It's only in a package. So we are at such an early stage in our understanding of what we're doing that sometimes it's shocking to think how much we don't understand about what we.
Well, it's shocking that we keep spending 90% of federal research funding on treatment packages compared to another treatment package to say they work the same.
Yeah.
I would say we do have, I think, some better evidence for change principles.
Yes.
Within those processes or principles of change, we don't have any evidence to say, should you do meditation, mindfulness, progressive muscle relaxation, biofeedback, autogenic training. The general principle of let's help an anxious person relax That's a good principle with
Yeah.
lots of research, but which technique or method works? No, we have no idea.
So I'm curious, regardless of technique or approach that we're using, what is the importance of the confidence of the therapist?
Oh, good question.
There's a great deal of impact on that. And in our most recent set of meta-analyses on psychotherapy relationships that work, we tried to meta-analyze that literature. Unfortunately, it's a mess. There is better research on credibility, how the patient sees the treatment is credible, and as the patient sees the therapist is credible. Far less research, ironically, on therapist credibility. You think there'd be way more on the person you're seeing, but in fact, there's way more in the treatment method. And that is positively associated and predictive of good therapy relationship. You need to trust, you need to have
My
vulnerability.
belief in whether a particular approach is going to be helpful. Like if I think EMDR or STDP, or if I
Correct.
think that's going to be helpful, that.
And indeed, that positive expectation does in fact predict outcome.
So is that placebo?
It's expectation. Belief half the cure. You probably have heard that a few times. So I would not call that placebo, but it's certainly partly belief. And there's things, of course, as therapists, we can do to enhance that credibility. Saying this is a research supported treatment. I've used it many times. Here's how we do it. So it's just not the placebo in that they believe it. We can enhance that credibility.
So, what about demonstrating to the patient how doing X, Y, and Z in a very limited fashion helps the problem, so that they then find that indeed they do feel better right away then when they do that, and then they say, wow, maybe there's something here, and then you expand it and expand it and expand it. Where does
So
that?
it's my first supervisor would have said, we want an explanation as well as an experience, Michael. Once a patient has that initial successful experience, then both their motivation and their credibility build and builds. It's a bit like priming the pump.
Mhm.
You get the patient into it and working. So that's exactly what I do. I don't just want to explain to them how it works. I'll say, let's take a moment right now and practice something. And of course, we've known from, I guess now, well over 60 or 70 research studies that practice between sessions also enhances subsequent improvement. Whether you call it homework or not is sort of a moot question, but between session exercises, have patients do something. That's the real proof of the pudding.
Yeah, if they're not, I find that if they're not looking in between, they're not going to do as well. I mean,
And that's exactly what the research, and frequently I like to say the research is finally caught up with clinical experience. Any patient who's willing and actually doing things between session is going to be more motivated, more engaged, more committed to the process. So I think we've known that for decades clinically. Now we can say, and research supports it too.
my wife will be very happy, and that when I tell her, well, I'll start exercising later, and she'll appreciate that I've heard this from you now.
You're going to start exercising. You're going to start exercising later. Well, there's a new book out right now, and I forget the name of it, but one of my patients was actually telling me about it. And what he said was that you should create a goal that you can't fail at. And one of the examples apparently in the book was that if you want to start exercising, you shouldn't say, I'm going to go to the gym every day for an hour and work out, because the first day you don't go, the habit's not formed. It's like you're off track. But pick one thing that you can't fail at. So the guy one of the examples in the book was a guy who decided to do one push-up a day. So he's down doing his one push-up, and he's down doing his one push-up, and he thinks, I'm down here now, I can do two, and then but
I like that.
to
Yeah.
set goals that patients fail at is an interesting sort of phenomena that we encounter, like, because the patients are in patterns that often are lacking self agency and discipline, and so they start something and they stop, and it's so hard to get them to start. And how do we? So I guess that's
You reframe. Yeah, it's the fall forward business. You know, it's another chance. Look how we can fit that right in.
So I want to shift a little bit, John, and just get your take on what's going on and what neuroscience is contributing to our understanding of our field. And I'm thinking about some of the work that's coming from like Bruce Ecker in memory reconsolidation, and a lot of that kind of converging evidence that shows that in order to really change, you've got to open up or light up the neural circuits, which is kind of what exposure therapy is, right? You can't erase the whatever script or whatever charges in those neural circuits unless you awaken them. And so I think exposure therapy does that. How do you understand what neuroscience and what is contributing to our understanding of change in psychotherapy and human change processes?
Well, I suspect I may be offending some people here, but actually I think very little.
Okay.
I think what it's doing is renaming what we already know. Here's an example. You just talk about relighting. We know from good research, recently reviewed in a meta-analysis by Paul Peluso and Robert Freund, that the more affective engagement a patient has in a session, the better the result.
Yes.
Well, if you wish to relabel that as neural awakening, well, go ahead. Freud told us years ago, we're not erasing anything, right? We're adding new memories, we're reframing it, we're reconstructing it. We may be desensitizing it, but we're not taking things away. So when neuroscientists say those things, of course, in their particular language, I'll say, yes, we know that. That's very helpful. But with the exception of the stuff in trauma and an occasional beta blocker early after a trauma, I honestly have not been impressed with the yield whatsoever from neuroscience for the daily practice of psychotherapy.
Mm-hmm. So you're not too into the neuropsychotherapy approach, which is, to me, is like more like a framework that people use to depathologize the process. Like it's really your limbic system that is stuck on the on circuit, and it's
Well, Jeffrey, we've been old enough to know that every couple of years we help patients not absorb responsibility for their mental disorders. We used to blame parents, genetics, neural, COVID, isolation. So I do believe, right, every patient needs a rationale somehow to explain it. Certainly not to become hopeless about the ability to change. But you asked specifically, are they giving me any tools to enhance psychotherapy? I haven't seen them.
okay.
And I keep reading the books, looking for it.
Uh-huh.
And then they say things just like you said, but we have to light it up. And I say, oh, you mean have affective engagement in psychotherapy,
yeah, I mean,
which
that's
we've
what they're
known for
saying.
40 years?
Yeah,
No
yeah,
shit, Sherlock.
Yeah, that's
Mhm.
exactly what they're saying. Yes. You have to have active engagement because learning is best enhanced by emotional activation, right?
I just went to a whole hour conversation on, did you know that attachment between people helps patients get well? I said, for 30 years, I guess I should have really been looking at psychotherapy relationships that work.
Mhm.
And I'm like, come on, folks. So you can reformulate it and repackage it as an evolutionary strategy or as a neurological strategy. But yes, the therapeutic relationship works.
But
I've known that.
But isn't that
Okay.
what our field does? Just kind of repackages and reiterates, and have we made any advances, John?
We have. I'm asked that
What are
all
they?
the time. Look, we know which elements of the therapy relationship work. We didn't know that. We've spent now the last 25 years, 50 meta-analyses. I could tell you these therapy relationships work in general, these behaviors not so much. I can tell you. So when I was back in training, we all know we need to personalize. I heard a new therapy for each patient at least 45 years ago, but we never knew exactly how to do it. And some of the ways I was taught are now sheer nonsense. In fact, the first way I was taught was to solicit patients' favorite colors. You may remember back in the day, color therapy. Of course, it's pure nonsense.
Wasn't that the Lucier color?
The Lucier color test. There you go.
Yeah, I remember.
Well, we
doing that
now
with my
know
friends.
we could be demonstrably effective by personalizing to a patient's ethnicity or race, stage of change, reactance level, attachment, coping style. And we are decidedly more effective in a shorter period of time. Overall, our efficacy has not improved dramatically, with a couple exceptions, but we do it in much shorter periods of time.
Is that true? Huh?
It is. Well, think about it. Your average number of sessions in private practice now is somewhere in the 6 to 10 range.
Really?
When I started, it was short-term psychotherapy was below 50 sessions, right?
Wow.
Yeah. Huh.
And we're much better with trauma, OCD, panic, medications, superior now to what we had. So we are better,
That's
demonstrably so.
That's hopeful.
Where,
That is hope.
what does the research say about therapist self-disclosure? And
So
Sure.
Clara Hill has done some great research on this. And Jeffrey, I could send you a chapter if you want to put it up there.
Yeah.
So it's mostly analog studies, which are positive, but Clara Hill performed a qualitative meta-analysis and find when self-disclosure is used judiciously, meaning sparingly, friends, in the interest of the patient, not to gratify the therapist's needs, it is almost always helpful. It gives patients a sense of universality, of support, of that the therapist is there, but it must be used sparingly when the patient needs it, not when the therapist feels a need to bleed.
That makes sense.
Mm.
It sure does.
Yeah. When you're working with patients who are hurting, you tend to hurt too. You feel it. And if you share it, that you hurt, they feel somehow understood. They feel you've witnessed it. You're there with them. Where do you put that on this judicious use? Because it is you, it's real. You're having it right then and there. And it's telling them actually helps them, and then they make you feel better. And there's kind of a ping-ponging effect.
Yes. So that's a reciprocal self-disclosure, a process of immediacy, and also some deep empathic attunement. I think you're probably at the confluence of those, actually.
Interesting.
So the patient is reflecting something deep, feeling that sense of suffering, or you call it pain. They share that as a self-disclosure, but in that moment of sharing that, that's sort of an immediacy process. Right now, I feel that pain. I'm trying to communicate that to you and join you in that. And I want that to be useful and tangible for you in a way that works. So it's a concrete example of attunement that helps the patient. So unfortunately, Michael, I find most therapists totally miss the boat on this, and they just say something dry and almost vapid, like, oh, you're really hurting.
Mhm. Yeah.
It really requires more of a presence and a genuineness to be in there and to feel vulnerable, and in that immediate process to communicate that hurt back. That's what's curative, not just saying, oh, that sounds terrible.
Yeah,
So on that note, we are going to have to stop for this evening. John, I want to thank you for joining us. This has just been so illuminating. It's always a pleasure to speak with you. We're going to stop our recorded version, and for people who are watching, they can hang with us and have more of an. We're going to have more of an informal discussion for a little while afterwards. So thank you all for attending, and thank you again, Dr. Norcross, for a wonderful discussion. And hope to see you all next month.